Okay, everyone's ready. We're going to get started. This is the myths versus facts, taking the fear out of hospice and palliative care, another conversation presented by Weinstein Hospice. Good evening. I am Richard Bressler, Vice Chair of the Board of Advisors of Weinstein Hospice, and we are going to set the record straight about palliative care and hospice care at Weinstein in the next hour. Weinstein Hospice is a nonprofit organization that provides comfort and the highest quality hospice care at home to people confronting life-limiting and end-of-life illnesses and their families. An important part of Jewish home life, Weinstein Hospice provides an important part of the continuum of care. Inspired by Jewish traditions and values, Jewish home life helps families face the journey of aging through an extraordinary network of lifestyles, healthcare, and support services, no matter where you choose to live. In order to clarify what is and what is not palliative and hospice care, we have two expert panelists from Weinstein Hospice. We also have Cheryl Johnson here, our executive director, in case a question arises that she would like to comment on. But first, I want to introduce Christina Olson, and then I will introduce Carla Polikoff. Christina Olson is an expert in Weinstein Hospice's palliative care program. She's a board-certified nurse practitioner specializing in internal medicine, gerontology, and oncology. She received a BS in nursing from Alvino College and MS in nursing at Concordia University, and also was a nurse educator at Froedtert and the Medical College of Wisconsin. At Weinstein Hospice, she serves as the advanced practice provider alongside our medical director, Dr. Syed. To stay young, she leads an active lifestyle of tennis, golf, hiking, and reading. We will hear from Christina in a moment. Born and raised in the Mississippi Delta, Carla Polikoff is definitely not singing the blues. She is an expert on Weinstein Hospice's hospice care program. She is a social worker and community educator for Weinstein Hospice. She received a BS from University of Texas and a Master of Social Work from Tulane University. She's been a social worker and educator at Emory University Hospital, Southeast Brain Tumor Foundation, and is very knowledgeable about what to do with Atlanta people facing end-of-life choices. So throughout the program, if a question arises, please put your questions in the chat box. We prefer that over the Q&A box so we can directly answer the questions. Let's start with Christina, who will give us an overview of palliative care at Weinstein Hospice. Now, let's let Carla give us an overview of hospice after that. So let's start with Christina.
Sure. Thank you so much, Richard. My name is Christina Olson. I am the nurse practitioner for Weinstein Hospice and Palliative Care. I am a board-certified adult geriatric primary care nurse practitioner. At Weinstein, I serve as a resource for the amazing team of nurses and social workers that manage the day-to-day care of our hospice patients. I also provide consultative guidance and support to patients on our palliative program. My focus here today is to highlight palliative care in general and then to speak to Weinstein's program in specific. So, what is palliative care? Well, palliative care is care directed at the relief of symptoms, including pain and stress of chronic illness. A palliative approach works to improve quality of life, reduce need for hospitalization, and in some cases, prolong life. Palliative care is provided in partnership with the person's regular team of clinicians and concurrent with disease treatments. Here at Weinstein, our palliative care program is community-based and consultative. The care is provided in your home. We come to you. Our goal is to serve as a trusted resource and guide for advanced care planning, as well as a partner with your referring physician to provide recommendations that are laser focused on your comfort. We can assess additional social work, chaplaincy, and volunteer resources based on your needs. And the benefit of palliative care really is refinement of your goals and values, better management of symptoms, relationship building, and an honest partner in your care who will help with the transition to hospice when the time is right.
Okay, now let's let Carla give us an overview of hospice care at Weinstein Hospice.
Thank you very much, Richard. As mentioned, my name is Carla Polakov, and I am a community educator and social worker with Weinstein Hospice in Atlanta. Oftentimes, when people call into Weinstein and inquire about services, I'm the first person that people speak with to get questions and concerns addressed before determining if it's the right program for them or not. There are lots of misconceptions about hospice care and palliative care. And in general, hospice care is specialized care that focuses on comfort, symptom management, and quality of life when it's determined that someone has a prognosis of likely 6 months or less. It is a program that is recognized by Medicare, Medicaid, and most insurance plans, and offers an interdisciplinary team that focuses on comfort from a holistic approach: physical comfort, emotional comfort, and spiritual comfort. In order to be eligible for hospice, there's only 2 criteria. Number 1 is that a physician has to feel like your loved one has a likely prognosis of 6 months or less if it were to continue its natural disease process. The only other criteria is that it's something that the families feel philosophically comfortable with. Despite what people are recommending, some people do want to pursue curative, life-prolonging measures, even if not recommended by their medical professionals. So we do want people to feel comfortable with shifting the focus to quality of life, dignity, and respect when it's determined, again, that they're at the end stage of life. And when someone decides to utilize this benefit, it opens up a full pot of services and an interdisciplinary team that's making visits into the home or anywhere that someone considers to be their home environment.
So those are 2 great overviews of the palliative and hospice program at Weinstein Hospice. However, we think that there are some beliefs out there that may be true or may not be true. So we've gathered some beliefs and we're going to walk through them, but I suspect you also have some beliefs that you're just not sure, is it true or is it not true? So please put them in the chat box and we will review them. So let's start with the first one. A belief is that hospice is only for people that are symptomatic and with death imminently right upon them. Carla, would you address this?
Absolutely. So often people are waiting to speak about hospice and have conversations about goals of care until they only have days or weeks of life to live. Many people think that hospice is not appropriate until they're homebound or bedbound and actively having pain or shortness of breath or another symptom. And this is absolutely untrue. As mentioned before, anyone who has a prognosis that the doctor determines to be appropriate for hospice and is not seeking curative, life-prolonging treatment is eligible for the hospice benefit. Someone can be up and about, people can be out of their home enjoying life, and hospice may still be an appropriate option. Ideally, we encourage people to seek hospice support before they're in crisis or really need it. If eligible, a team of people will go in and build a rapport. And if nothing is needed for symptom management, that's absolutely fine. But at least we're prepared and educated. So if and when symptoms do occur, it does not become a crisis situation. So many people are living between doctor's appointments and going back and forth to the hospital because they don't know what else to do. At the same time, they're not seeking aggressive treatment or they've been told that there's no further curative treatment. So we're trying to dispel this myth to say, what is there to lose by having extra special care and support in the home? If someone is not wanting to go back and forth to the hospital, hospice is probably one of the only programs that respects that. There's some people that are on hospice for much shorter than 6 months. We have some people that are on much longer than 6 months. We don't have that crystal ball to predict, but if someone meets the criteria for hospice, it's really about saying whether they have days, weeks, months, or years, they deserve to be as comfortable as possible for as long as they may live.
Okay, thank you. We have a question, and it was actually going to be our next question. and that is a physician must bring up hospice and or palliative care in order to utilize the services. Let's have Christina chat about the palliative piece of this.
Sure. So for palliative care, patients can be self or family referred. However, an order from their collaborating physician is required for admission onto our palliative service. Patients can request a palliative consult just if they're just interested in discussing comfort measures, or even just talking more about goals of care moving forward, or what next steps are if their current treatment is not effective. I think with this myth, it's also important to note that even if your physician recommends hospice and you're just not psychologically ready to proceed with that, palliative care can be a good source of support as you continue on your healthcare journey.
Carla, what about the hospice side?
I agree. I'm a big proponent of the more knowledge, the better. Physicians obviously are brilliant, but many of them feel very uncomfortable bringing up the concept of hospice and palliative care. They're scared that by having that conversation that their patients and families will feel like they're being given up on or giving up hope in any way. So what I find is for families that call us and are seeking information, or the ones that are actually bringing up the topic with their doctors, many times the physicians have this huge weight off their shoulders to say, you know what, that's an amazing idea. They just are not really comfortable having that conversation because, again, when you traditionally go to physicians, the point is for them to make someone better. And oftentimes that involves curative treatment. So to bring up a conversation where cure may not be an option, or again, patients sometimes don't want to disappoint their physicians by saying, you know what, I love seeing you, but I no longer want to come back here and have lab work. It can be a very difficult conversation. So someone can bring it up at any time, and you might notice that the doctor feels a sense of relief. At the same time, if a physician does not feel like it's the appropriate time, they're going to be honest and say, no, I don't think we're at that point. As Christina mentioned as well, though, sometimes physicians will say, you know, I think that your loved one needs hospice care. We're at the end of the road when it comes to what we can offer. And I want to share that even if a physician recommends hospice care, that does not mean that someone has to be on hospice. People have a right to continue to pursue aggressive treatment and second opinions and return back and forth to the hospital. That is just not hospice care. So even if the doctor brings up hospice, if you do not philosophically agree with it, it is absolutely not something you should feel forced or pressured into.
Okay, thank you. So still in the physician piece, a belief is that I must give up my physician or physicians to enroll in hospice and or palliative care. Christina, true or not true?
This is a myth for palliative care. So Weinstein Palliative Care does not limit who you can see in regards to physician visits. In fact, you are required to continue seeing your referring provider. Palliative does not take over for primary care. So yes, you can continue to see your oncologist, your cardiologist, pulmonologist, or any other specialist you choose. After visits, recommendations to help alleviate your symptoms are provided to your referring physician, and they still remain in charge of the plan of care and are responsible for the oversight of medication management.
Okay. And Carla, your perspective on this, giving up a physician?
That's absolutely untrue as well when it comes to hospice care. To be honest, that when someone is referred to hospice by a physician, that physician is always given the ability to remain the attending physician under hospice care. However, when someone goes on hospice, it means that we are answering to families and patients 24 hours a day, 7 days a week, because when the goals are comfort and symptom management, it's not a 9-to-5 job. And the majority of physicians in the metro area just do not have that availability. So they will turn day-to-day care over to our medical director, whose expertise is in pain and symptom management. That does not mean that you lose contact with your physician. You're welcome to still consult with them. And Weinstein is more than happy to send them bi-weekly updates as well. Also, if you have physicians that have absolutely nothing to do with the diagnosis of why you're enrolling on hospice, you absolutely can continue to see them under your insurance benefits. This would be a dermatologist, a podiatrist, an ophthalmologist, etc. If someone comes on to hospice with a diagnosis of cancer, the hospice doctor and team are becoming responsible for the symptoms and that disease process. However, if there's things completely unrelated, you will go to a specialist for it if needed. However, we can manage day-to-day care and almost become primary care in the home because our nurses and staff do have eyes and ears on the situation much more frequently than you would with standard doctor's visits.
Okay, thank you for that. Here's a hospice question. All standard medications and medical care are discontinued in hospice, and only comfort medications are continued. Therefore, it will, by that effort, will hasten the end of life. Carla?
So that is absolutely a huge misconception about hospice. I think people think when you sign the paperwork for hospice, we come in and throw out everything that's in the home and put someone on pain medicines and oxygen and stop everything else. In my years of experience, rarely is that done. Most people we care for are on multiple medications, and we're coming in to meet them where they are. Rarely are we changing anything. And the majority of time, people have multiple issues going on. So on top of the reason that they're on hospice, they also have blood pressure issues or cataracts or diabetes or hypothyroidism. We absolutely want our patients to continue those medicines as long as they are needed. At the same time, if someone's body is declining and they're no longer needing those medicines, we're here to be very open and honest about the ones that really should take priority, that are going to affect how they feel today, tomorrow, next week, next month, versus the ones that they've just been on for years just for the sake of it, that haven't been changed. And certainly as the body changes as well, sometimes it's difficult to swallow and actually take so many medicines. So we are there to simplify things if and when needed, but it's absolutely a myth that we would come in and stop any day-to-day medicines that are needed for someone's quality of life to keep them comfortable and keep them stable.
Okay, thank you.
Mhm.
I would think that some of these thoughts would raise other questions from the audience. So please put it in your Q&A box, and we will answer this as soon as possible. But hospice and palliative care provide 24-hour caregivers. True or not true? Christina?
This is not true. For palliative care, we do not provide 24-hour caregivers. We can assist with referrals as needed. Palliative care includes a nurse practitioner visit. This is based on medical necessity. My visits are billable, similar to going to your provider's office. This means there has to be a chronic symptom to address or goals of care to discuss. The visits aren't home health nursing visits or social check-ins. However, you can continue to have home health care nursing or home wound care or therapists coming in on palliative. I see my patients with varying frequency based on their medical needs. For some patients, this is monthly. For some patients, this is every 2 weeks. And this is usually when we're having more acute symptoms and we're needing to talk more about goals of care and possible hospice transfers. I also have patients who are seen every 6 months or just as needed based on the stability of their disease process.
Okay. And Carla, the hospice perspective on 24-hour caregivers?
That's also a myth. Hospice is a program, again, that's regulated mainly by Medicare. And under Medicare, our interdisciplinary team are making skilled visits into the home. Every time we visit, we stay as long as needed to complete the skilled task and make sure that our patients are comfortable and that the family feels comfortable with the plan of care and what's going on. But legally, when we're done with the visit, we must move on. So no one from hospice is in there just to watch someone or be there for supervision. It usually does take family or private caregivers in order to follow the hospice plan of care. I often use the analogy that we become the quarterbacks for the team. So your hospice nurse and social worker and aide and chaplain are coming in to develop a plan of care and give instructions and all the tools necessary to manage your loved one that's under hospice care. But the family or caregivers are the rest of the team. They're the ones that are following the plays that we are writing and putting in place. If someone does need more support than hospice provides, the social workers and the team are more than happy to refer to very reputable agencies and private caregivers that can assist, as well as look at community resources.
Okay, thank you. So once enrolled on hospice or palliative care, my loved one will receive services for the remainder of his or her life. True or not true? Christina?
Sure. So this is for palliative care, it's a little bit different. So palliative care is not a Medicare benefit, as I was talking about in the prior slide, but so it's not limited to benefit periods. Typically, patients can stay on palliative care as long as needed or until they transition to hospice care.
Okay. So a question from the audience: can hospice patients leave the home, like for errands and family visits, if they're up to it? Or are they restricted to stay home in order to receive hospice services? Carla?
People do not have to be homebound to be on hospice. People may be familiar with home health care under the Medicare or insurance benefits that requires it to be home or take taxing effort to leave the home in order to qualify. With hospice, people can be out and about. They can be going out to dinner. They can go to yoga. They can do whatever they enjoy and brings them quality of life, as long as it's not stressful to them. And we actually encourage anything and everything that brings quality of life to someone. People can even travel on hospice, and we encourage it. So if someone wants to go to the beach or to the mountains, we can actually contract with a local agency wherever they're going, so that if they get into crisis or need a visit while there, they can even have hospice support anywhere in the United States that they visit. So again, as long as someone is safe to be out and about, we're going to give them the equipment and the medicines necessary to be comfortable and do what they enjoy.
Okay. And here's a question for palliative care. Why would someone go on palliative care?
To receive supportive services focused on their comfort and to discuss options regarding goals of care and what's important.
Okay. And how does Weinstein work with doulas? So I don't know if this is a hospice or a palliative question, but I have a secondary follow-up question on assisted death. You know, probably not legal in Georgia, but I'm sure that subject has come up for somebody. Carla?
Yeah, I was going to say it is not legal. We are not doing anything to hasten end of life. Yes, we are giving people medicines and resources needed if and when they are symptomatic, but we are not giving it to them with the purpose of stopping life any sooner than it would. Any medicines that are given, it is not enough to stop the heart from beating or keep someone from breathing. It would really be just to alleviate symptoms and allow the body to relax so that it can do what it's naturally going to do. It's a controversial topic, and it's often painful to watch your loved ones in this kind of in-between state of being with it and not with it, or being close to end of life. But hospice is not going to do anything for someone to die any sooner than they're supposed to die.
Yeah. And Christina, what about doulas? Has that issue ever arisen?
It hasn't risen yet in palliative care in our program, but that's certainly another provider we could collaborate with. I mean, the point is to kind of be that touchstone between all of the different providers and help sort through the information and promote comfort in any way that, is desirable for that patient.
Yeah.
And if that involves incorporating a doula, I would absolutely support that.
Yeah. And it's something we're seeing more people get into these days. And I have seen families hire what they call death doulas. And what we're doing is coming in and again, providing the resources, the education, the knowledge, so people are not on the edge of their seats and fearful of what's to come. Oftentimes a doula may be hired by the family to come in and actually sit there with the patient at end of life and do whatever they can to ease that process. So I would say that they're a source of emotional comfort for the family and the patient, and also with knowledge of what the body naturally does as it shuts down. So we would definitely collaborate with them. And in a way, hospice is, many of us are kind of death doulas, although we don't technically go through that. We're there to ease the process, to allow people's bodies to relax whatever they're holding on to physically or emotionally or spiritually, to make sure that that is not hindering the process. And again, we don't know when someone's life is going to end, but we don't want to have anything distressing holding that person back from dying when it is time.
Yeah. So what you both described for Weinstein Hospice, palliative care, and hospice seems almost too good to be true. How much does it cost the patient to access each of the care? Let's start with Christina on palliative.
Well, so the nurse practitioner palliative care services are billed directly to Medicare, Medicaid, and most private insurance plans. If there was any question about cost of services before coming onto the program, we could always have one of our, intake specialists help coordinate and verify financial concerns before the service begins.
Okay. And Carla, how much does it cost for hospice care?
Absolutely nothing. Medicare, Medicaid, and most insurance plans cover hospice at 100%. When I speak to families and explain the ins and outs of hospice, it's often hard to believe, because when does Medicare or insurance ever cover anything at 100%? Medicare Part A, which is the same part that pays for someone to go to the hospital, covers hospice at 100%. And unlike any other program that specifies you can have X number of visits this many times for this amount of time, it's really an indefinite benefit as long as someone continues to be appropriate. So whether someone needs 1 nursing visit a week or 3 nursing visits a week, whether someone needs no CNA or a certified nursing aide 3 days a week, whether someone needs 10 comfort medicines or no comfort medicines, it's really up to Weinstein or any hospice to be very good stewards of the benefit and make sure that anyone who's enrolled gets anything they need to be as comfortable as possible for as long as they are on service. And that goes for most insurance plans as well. We do work with people that have commercial insurance, and rarely is there any kind of copay, or if there's any out of pocket, it's usually maxed out before someone actually comes on hospice. As well as as a nonprofit, we will consider people as well that have absolutely no source of payment as well. And we believe that everyone, regardless of ability to pay, deserves the best care and comfort, dignity, and respect at this stage of their life.
Okay. A question from the audience. If a patient is already at the William Bremen Jewish Home, how does going on hospice change the care being given now? And I'd like to amend that to, how does the care going to palliative care also change? But let's start with hospice. Carla.
So when someone is in the William Bremen Jewish Home, or really any nursing facility, the care at the nursing facility remains the same. So the staff there are responsible for the day-to-day needs. So helping with continence care, feeding, bathing, changing, that kind of stuff. However, we're coming in again as the quarterbacks on the team. So a nurse, a social worker, and the full team from Weinstein would be assigned to a patient in the Jewish home and are going up to make skilled visits there to really advocate and oversee the care with the goals of comfort and symptom management. So our nurses are coming in with eyes and ears and laser focus on your loved one at the Jewish home to talk about what's working, talk about what's not working, picking up the phone and calling the doctor if there's any discomfort noted or any new symptoms. We're there to educate the staff at the Jewish home when to call us, what signs and symptoms of discomfort, and really put a plan in place. So again, if your loved one becomes uncomfortable in any way, it's not this moment of, oh my gosh, what do we do? What do we do? It's really, oh, the nurse Joy told me if this happens, there's orders in place and we can give mom or dad this medicine and it should be effective like this. Or the staff has access to call us 24 hours a day, 7 days a week. So instead of them being nervous about everything happening on their shift, they have people they can go to for anything and everything that are going to be knowledgeable about what's going on with your loved one, be able to instruct what needs to be done right then and there. And if needed, we can make a visit as quickly and as soon as possible.
And Christina, on the palliative care side, if a patient is already at the William Bremen Jewish Home taking palliative care, how does that change the care that they're getting currently?
Well, it would be an extra layer of support. Somebody else coming in who's focused on symptom relief, really. I would be a resource to talk to their primary medical director at the Jewish Home. And I could talk about, different kinds of strategies to manage their pain, nausea, anxiety, depression, constipation, a myriad of symptoms that, could improve their quality of life. So it's focus on that. It's a second opinion. It's another layer of support. And also to help kind of communicate with the staff as well and touch base with the family.
Okay. Are there controls on the palliative care offered at Weinstein? I don't know what that means though, but
Control.
a person is asking about controls. Not really.
Get a clarification question.
Yeah, we should get a clarification on that. And there's another question about what a doula is specifically, but you talked about, death doula. And are there other kind of doulas out there?
There's birth doulas.
Yeah, right.
But yeah, I think they recognize that there's people that help assist women when they're giving birth. And just as important as it is bringing life into this world, it's important to have dignity and respect and wishes respected at the end of life as well. So while I'm not an expert, I don't know what certification goes into it. It's something that people see value in to make sure that when someone dies, they have the dignity and respect they deserve, and that any plans and things they wanted to take place at that time are followed through.
Okay. So here's another belief. All hospices are the same. True or not true? Carla?
That is absolutely not true. In the Metro Atlanta area, there are over 100 hospices. And technically under Medicare and the certifying body, we are all required to provide the same clinical support. And what I mean by that is any hospice you speak with will have a nurse case manager assigned. There will be a social worker. They're to offer certified nursing aides. There's to offer a medical director. Some of the main differences that I think set some apart from others and some of the good talking points, I always recommend speaking to more than one hospice to see what you feel and what kind of feel you get from the organization. Is the agency a for-profit? Are they non-for-profit? Again, this may or may not affect care, but is important to many people to know how any monies that are made, if it's put back into the program or not. Also, the actual retention of employees. With so many hospices and with healthcare in general, as you know, there can be a shortage of employees, and sometimes agencies have a revolving door of nurses and aides and social workers and volunteers. So I think it's important to know about employee retention. Also, coverage area and service area. Some hospices are very large and service 10, 15 counties from multiple offices. And some hospices are very small. Weinstein, we kind of consider ourselves a boutique program. We're small. We keep our census low so that, again, the nurse to patient ratios can be lower than average. Also, it's important to know, again, we all have to have medical directors. Is the medical director accessible 24 hours a day, 7 days a week? Do they work 10 different jobs? The same goes for on-call staff. Anytime someone goes on hospice, you will have access to the agency and a number to call 24 hours a day. It's important to know that the people that answer those phone calls are competent, that they're full-time employees, that they are not praying and crossing their fingers that no one calls at night because they're trying to sleep because they work full time during the day. Those are some of the differences. These days, there is a website under Medicare.gov called Hospice Compare, and it's actually a survey that is sent out to anyone who is utilizing hospice services after the fact when their loved one no longer needs. And you can go to Medicare.gov to look at some of the latest survey results in the Atlanta community. If you're interviewing multiple agencies, they have pulled up results for Weinstein and how we fare, but you can do that for any organization to get a good understanding. It's very hard when you're told you need hospice, and if you Google, it's a million. There's a million different responses, so it's really hard to know which one is going to be right for you. So it's important to do your research, to ask around, to ask friends of friends, to post on websites, and then to actually call and speak to sometimes multiple to see what kind of feeling you get. Are you feeling like you're being marketed to? Do you feel like someone's trying to sign you up just to get a commission? Or is it someone that's personally involved and takes it as their responsibility to educate? So those are some good points to look at, but absolutely all hospices, while we all have to provide the same support across the board, are very, very different.
Okay, thank you. On this page, it's small on some of your computers. So if you will just take down that website, https medicare.gov/care-compare, I think that would be great for everybody. I'm going to skip a question and come back to it in a second, but what's the difference between inpatient hospice and home hospice facilities, and does Weinstein have that?
So Weinstein does not have a freestanding inpatient hospice. I'd say 99% of our patients are managed in a home environment, and due to our strong care teams are able to remain at home and be comfortable. However, there are people that are acutely ill where pain and symptoms cannot be well managed in the home despite best efforts by everyone involved. And that is often when inpatient hospice may be recommended. I kind of explain it as intensive care unit in a hospital. It's for someone that really needs constant medication titration, oversight by a physician daily, a nurse to constantly be changing medication. So if our staff can get someone on regularly scheduled medicines and they're doing well, you would not meet criteria for inpatient. Unfortunately, inpatient freestanding buildings are few and far between in the metro area these days. When I first moved here, there was one on every street corner, but I think most agencies realized it's very hard to pay for the overhead of inpatient hospice and keep it staffed, whether you have 1 patient or 12 patients. So many hospices utilize and contract with other agencies. Weinstein's very fortunate to be part of Jewish Home Life, which does have the William Bremen Jewish Home. And if someone is needing inpatient hospice and they are at home and there's a bed available at the William Bremen Jewish Home and they meet criteria, we can utilize a bed there. And then Weinstein will follow them and do daily visits and make sure staff is caring for their loved one around the clock to manage symptoms.
Okay, thank you. There's a question about the various pieces of Jewish home life. Weinstein Jewish Home, Zabin, William Bremen Jewish Home, Berman Commons, Cohen Home. Cheryl, will you kind of walk our audience through what the differences are?
Sure. So similar to our connection with Jewish Home Life, the William Bremen Jewish Home Life has grown in the sense of becoming one large organization over the course of the previous several years. So we are a senior living support network where seniors can age in place and have resources in the same community of Jewish Home Life. So seniors who live in any of our buildings, whether that's the Tower, Zabin Tower, Jewish Tower, the assisted livings, Berman Commons, Cohen Home, or at the William Bremen Jewish Home, they also have direct access to our home care programs, including Weinstein Hospice and Palliative Care, our staffing agency, X-Teen Home Care, as well as our medical services, JHL Medical Services, where nurse practitioners go to the patients where they live in our communities. So it's a well-rounded support system. So seniors have one-stop shop with JHL. So we're really proud to be able to offer that. And members in the community are always excited to hear that they can refer to one place and have all of their needs met as their loved ones age in place.
So that's interesting because we have another question directly related to that, that a patient is at William Bremen Jewish Home and the staff there is suggesting hospice for the patient. The mother has dementia, but they stress she's not near the end. So how do you determine that it's a 6-month diagnosis? And how do you evaluate when a staff at William Bremen Jewish Home is suggesting hospice? Carla?
Generally, if it's being recommended by the staff is being overseen by the medical directors there. There's 2 medical directors at the William Bremen Jewish Home, and both are very well versed on hospice care. We are happy to educate anybody who expresses an interest in hospice care, whether it's appropriate or not. So if the staff is bringing it up to the family and the family wants to hear more, we're happy to kind of dig in and determine what's going on and then take that back to the medical director to determine if it is an appropriate option. Hospice these days, it's very kind of ambiguous because traditionally it was looked like as the end of life. And I think many people have had experiences now where they know someone who's been on it for months and months or sometimes years or more. Obviously, anyone that's appropriate, we want them to receive the gift of hospice and the benefit. At the same time, Medicare is very strict on documentation. We really have to feel like we would not be surprised if the prognosis is 6 months or less. We can't put hospice in place just because it provides an extra level of support or nurses to come in to give the extra attention that families need or loved ones need. So we do have to defer that to the doctors, but we are there to advocate for the families too and have this conversation with the doctor and have the doctor have the conversation with the family to discuss the reasonings of why hospice may or may not be appropriate. The good news is the doctors at the Jewish Home are very familiar with Weinstein and our role. So if they notice that someone's declining or they've spoken to a family and they know that the goals are for their loved ones not to go back and forth to the hospital or seeking a curative measures, our doctors are very good stewards of having these conversations and referring any of their patients to our service. And we try to get them on our support as quickly and easily as possible.
Okay, thank you. Christina, we have a question about palliative care medications. Specific ones that you use, or is it really what the patient needs?
Well, I think it's going to depend on what the patient needs, kind of their medical history. We do a whole deep dive into where the patient's been and where they are now. And, obviously we can make recommendations on things to pare down on if, the patient feels like they're taking too many medications. Or we can make recommendations to add comfort medications that would be obviously safe for them, that particular patient. But I think, you could definitely expect an improvement in your symptoms on palliative care, having that laser focused, outlook.
Okay, so we have a few more minutes if there are other questions that arise as a result of some of these Q&As that have already been answered. But what forms need to be used to coordinate with the VA and various hospitals in order to get into the hospice care or even into the palliative program?
Generally for hospice, and I think I can speak for palliative care as well, a doctor does need to write an order or send a referral to admit to either program, as well as basic history and physical, what's been going on most recently that makes them appropriate, and that they feel like they do have a prognosis of 6 months or less. Oftentimes, the physicians in the community are very, very busy and are not as responsive. So our intake department, Kristen in intake, if anyone ever calls and inquires and speaks to her, she also has some pre-printed forms that she can send over to doctors' offices requesting the information, requesting an order. She makes it very easy. They can either check here if they want to continue to be the attending physician, or if they want biweekly updates and just sign. And usually they can get stuff to us very, very quickly and easily. We know that doctors and hospitals get many, many requests each day from all different kinds of care providers. So we're trying to make it as simple as possible. We often will encourage the family to also call so that the doctor's office knows that we're not just soliciting for the family and the family truly wants this to happen. So usually if we can kind of hit them on both ends with the family saying they want Weinstein or hospice, and our office usually will get things pretty quickly and then can get things scheduled to get started. And the same for palliative. I believe if someone's interested for palliative, Kristen and intake can also send a request for palliative care and the records required to get that initiated as well.
Right. There is a standard consent form. And then if they're not already filled out, that's another thing that we can help out with on palliative care is formulating and filling out advanced directives, post forms, living wills, all of those documents that help outline goals for managing healthcare.
So in addition to the great questions that our audience has put forth, they have also put forth some compliments of our team of Carla and Christina for not only answering well and covering the subject so well, but for the care delivered, because they have, some of these people have loved ones in the program already. And so it's always good to hear that. If other questions do come up at some point in time, as you're thinking through some of these things, we have a way to answer them going forward. So let's pull up the next slide. And that would be to call 404-351-1897 or go to the website and you can formulate questions there and the same team will be able to answer your questions or give you a more thoughtful answer about your specific situation. We have another conversation webinar coming up in about 2 months on Thursday, May 18th. And that will be a very interesting subject called Operation Lockdown, Navigating Social Media After a Critical Loss. But it's actually going to be more than that. It's preparing social media passwords and what have you, but not just social media. It's all of your accounts that are accessed online. Somebody's got a password for that. And gosh, that needs to be as part of your file going forward. So it's going to be a very interesting review of that information with someone that does this every day. So it should be interesting. Any questions, any further questions at this point? I do have, let me see if I have somebody else. Nope, everybody, more compliments. So I think we're good. Thank you very much. And I think we're gonna end this. Thank you.
Thank you.